I'm going to introduce Dr. Naidoo, who's actually a medical oncologist, professor of medical oncology in the UK. She's at the Trinity College. And if any of you have been to Dublin, the Trinity College is something that you have to see. I saw it with my parents, and everything is, I don't know, like 1,500 years old. So she's going to talk to us about the long-term impact of systemic treatments for early-stage lung cancer.
Good morning, everybody, and thank you for the kind invitation to come. Yes, great to be here from Dublin, along with many of the other speakers. And today I'm going to talk a little bit about and build on Dr. Pompili's talk on long-term impact, focusing specifically now on systemic therapy for early-stage non-small cell lung cancer. These are my disclosures. So in terms of a framework for today, just to talk through really, what does impact mean? I thought this was something to focus on because I think medically, we think about this in different ways, and certainly the different stakeholders in the cancer journey think about this differently. And then how do we put some scientific rigor into quantifying what that impact means? What are the nuances with respect to early stage disease? How is impact measured or quantitated differently for metastatic disease as opposed to early stage disease? And what are some of the new tools, like Dr. Pompili has showed us, and some next steps for the field? So firstly, what defines impact? You're going to see what my favorite show of all time is here. So first of all, efficacy. We need to be effective. We need to use treatments that actually make a difference and our patients want to stay on. But with efficacy often comes toxicity, maybe in the same approach. And how do we seek a balance for that? We also need a clever mechanism of action, something which speaks to us as medical oncologists, as patients, and in the cancer journey. But even the cleverest mechanisms of action sometimes lose their duration of benefit. So where is that level, and how do we define it up front? Lots of things seem like they are a value add in the beginning and look perfect, but might ruin your quality of life. So I think we have to balance all of these into making sure that we pick the right treatment for the right patient at the right time, and obviously listen to the patient in developing that calculus. So thinking through some of the impactful treatments that we think of purely on the basis of efficacy in early-stage lung cancer, of course, targeted therapy has become now a standard of care based on the phase 3 ADAURA studies, the LAURA study in stage 3 after definitive chemorads, and now even in the neoadjuvant setting with neo-ADAURA, this is becoming something that we're seeing as a potential option. The second, of course, is in ALK. We heard about the ALINA trial, of course, and now we have 5-year data in the metastatic ALK positive setting. And of course, we heard from the president of ALK positive Canada today that really this is revolutionizing the treatment of this subset of disease. Also, again, moving into the neoadjuvant setting and defining new endpoints such as major pathologic response and pathologic complete response, defining whether these are the right endpoints in this type of disease. So what are some of the toxicities? What are some of the other impacts of these treatments? So again, to quote a patient advocate leader, Jill Feldman here, again, as Dr. Pompili showed us, she defines that tolerability and toxicity are not necessarily the same thing. But we have to find a way to quantitate this in a way that is understandable to all members of the cancer community, including stakeholders, regulators, and others. This is also true in ALK-positive disease. We saw the plenary presentation of the ALINA trial focusing on some of these toxicities and how they may persist and how they may not be truly represented in the proportion of grade 3 toxicities. I think what's also important here is to assess some of these rare but complex toxicities. So we know that when we combine osimertinib with certain other partners, or we treat with osimertinib after definitive chemoradiation, the incidence of cardiotoxicity is exponentially higher. We also know that when we combine osimertinib with thoracic radiation, sometimes we see cases of severe pneumonitis. How do we quantitate this and explain this to our patients in order for them to make an informed decision? This is very similar in the ALK space. We see some unusual side effects with ALK inhibitors, alectinib causing serious weight gain, neurocognitive long-term effects sometimes of lorlatinib. How do we quantitate this in a fair manner for our patients in order to decide what's the optimum duration of therapy. I think all of these questions really are the future questions of the field. And then we come back to immunotherapy. So we've talked a lot about neoadjuvant, but of course the first approvals came for adjuvant immunotherapy. We see here really that there was a modest benefit when we look purely at the efficacy endpoint of disease-free survival. The benefit was a bit inconsistent depending on the PD-L1 score, but largely was based on PD-L1 positivity. The impact of neoadjuvant chemoimmunotherapy we heard a lot about yesterday in terms of efficacy, a greater benefit in terms of EFS, now OS for selected regimens. We see PCR emerging as a potential surrogate endpoint for overall survival and others yet to be validated, but certainly many leaders in the field working on this, and the effect greater by PD-L1 score and stage. But what do we know about the toxicity? And how much does toxicity and the other related toxicities factor into our decision-making and our conversations with patients? What nuance do we bring to this, the same way we bring nuance around efficacy? So what we've learned in the last 10 years from all of the stage 4 studies is that we know there are a range of immune-related toxicities that can occur. And really, these can affect any organ system in the body, and some may lead to treatment-related fatalities, such as myocarditis, pneumonitis. Some may become chronic, leading to lifelong immunosuppression, like inflammatory arthritis. How much nuance do we go into with our patients about this? Who does it affect, and when? So for the next 10 years, I think we need to understand immune-related toxicity natural history. What proportion are acute, what proportion are chronic? Identify which patients have different IRAE risks. What are the pros and cons of doing empiric interventions such as corticosteroids? And are any of these treatments based on any understanding of the biology of these toxicities? Because these agents don't work in the same way chemotherapy does. They change the biologic milieu and the immunologic milieu of the patient. So the mechanism of efficacy and the mechanism of toxicity may go hand in hand or may actually uncover why some patients respond better than others. So a lot of my work and others have focused on this area. So what have we learned in the last 10 years? So thankfully in lung cancer, immune-related adverse events largely are low grade. So what we can say safely to our patients is a large proportion of patients are going to develop side effects, but these side effects are generally identifiable and treatable, particularly when they're identified early. And we see here that the incidence of these toxicities, all grades, is actually quite high, 60 to 70% with monotherapy, but the high-grade toxicities, lowish, 5 to 10%. But when we add immunotherapy combinations, we see an exponential increase, particularly in high-grade toxicities. Okay, maybe I need to direct this more cleverly. Okay, just failing to advance here. Okay, something's happening. I can see it down here. Okay, so I think one very important nuance is with every additional immune-related toxicity, there appears to be an incremental benefit in survival. So sometimes you can say to a patient, not fair, but the truth, the more it hurts, the more it works. There are some patients who get more immune-related toxicities, and particularly those that are low-grade, are associated with an incremental benefit in both progression-free and overall survival. However, an important nuance here, not all side effects or immune-related toxicities are created equal, and some are associated with poor outcomes. So in the first figure on the left-hand side that you see is a large pooled analysis of over 10,000 patients treated with an immunotherapy-based combinations with atezolizumab. And what we see here is that severity matters. So all toxicities that are severe are associated with a poor outcome. However, certain toxicities are driving that association. So those patients who, for example, in lung cancer develop pneumonitis, others in other cancers such as myocarditis, these are particularly associated with poor overall survival regardless of grade. So we need to be able to say these things, I think, in our conversations with patients in order to impart this nuance. Another very important fact is that immune toxicity can occur anytime and can become chronic. So this is a large paper that we published a couple of years ago showing that most of the toxicities with immunotherapy happen within the first 3 months, but many may happen months to years after the first dose of immunotherapy, and in selected patients, sometimes after they have completed immunotherapy. We know that the onset of toxicity is quicker in those who receive combinations and may be associated with high grade. We also know that there are these new emerging phenomena of immune-related toxicity that are difficult to diagnose. So a phenomenon which many practicing medical oncologists might have seen is this phenomenon of smoldering myocarditis. Patients who have an asymptomatic troponin leak, isolated chest pain, changes in their ECG, and they actually, if we do biopsies, which was done by the pathology and cardiology groups at MD Anderson, have developed a grading system for smoldering myocarditis, which actually can respond to very specific immunosuppression. Probably more commonly, we see that 10% of patients, particularly older patients over the age of 65, who are treated with immunotherapy may develop chronic inflammatory arthritis for which they require corticosteroids or some kind of immunomodulator for 3 months. And then in the lung cancer patients, we see up to 4% of patients will develop chronic pneumonitis, inflammation in their lungs that are associated with an active T-cell infiltrate, which we see here on multiplex immunofluorescence. And I think there's a lot of very interesting biology here which we can tease out in order to identify who are these patients, what are the biologic mechanisms, can we intervene in some way. So how do we quantify this impact? This is a paper that myself and my fellow put together for JAMA Oncology a couple of months ago. I think we need to understand and quantitate these different elements to immune-related toxicity. What are the subtypes? Late onset, chronic, recurrent. There are now validated definitions from some of our work. What about duration of toxicity? How are these toxicities managed? What proportion had resolution, stability, or worsening? How do these associate with Dr. Pompili's work, with patient-reported outcomes and quality of life measures? And are these validated in the immunotherapy population? There are also some novel measures of toxicity, such as time toxicity, financial toxicity, and health-related quality of life domains. So I'll walk through some of these. So this is a paper that myself and my co-chair of the immune-related toxicity group of Johns Hopkins, which we developed several years ago and I chaired with rheumatology. We went to the Society of Immunotherapy for Cancer and identified this as a gap in our knowledge. So this was a great paper in which we were able to bring together an expert group of over 25 specialists representing both clinical and academic oncologists, industry partners, regulators from both Europe and the US, nursing colleagues, allied health specialists, and organ specialists, where we took a series of clinical situations as well as the data, the primary data, to truly define what were the subtypes of immune-related toxicity. And so through this Delphi consensus mechanism, we identified these terms that you see in the immune-related toxicity literature, but had never been validated before. So recurrent immune-related toxicity, late onset, which we defined as greater than 3 months after immunotherapy discontinuation, chronic and active, requiring immunosuppression, chronic and inactive, not requiring immunosuppression, multi-system tox. And then in those of us who treat some of these complex toxicity patients, what defines steroid refractory, steroid resistant, steroid unresponsive, and steroid dependent? There are actually many different subsets of these immune-related toxicities, and they respond to different types of immunosuppression. So this is what our toxicity group at Hopkins led a lot of the papers in, and a lot of the work is ongoing. In terms of quality of life, we heard a lot about this from Dr. Pompili, so I won't belabor it, but I think that it's important, particularly in the immunotherapy era, to distinguish tolerability from toxicity. Some of these toxicities may be incredibly nuanced, where some may be very tolerable, and others may not at all, depending on duration and these other factors. So there are some novel measures by which we can incorporate and adapt our trials to try to understand this better. This is a great paper by Regan and colleagues looking at duration of toxicity. So as we report our Kaplan-Meier curves of time with response, time to progression, should we have a subset that has time with toxicity? And this will give us a proportion of patients and give them information about how it might affect both their quality of life and their lived experience. This is something that our surgical colleagues do very well. We certainly don't do very well in the field of medical oncology, is to evaluate the time it takes to give our treatment. And again, we heard a little bit about giving subcutaneous immunotherapy. This would totally change the game here. So we need to evaluate what proportion of time the patients spend coming to the infusion center, waiting for their treatment, monitoring for toxicity, and going home. This is indeed a measure of quality of life, and something that will change even with slight modifications in our treatment. Oncology trials are complete outliers. There is not a single oncology clinical trial that has ever reported time toxicity, and it is not considered a standard measure. We also heard a little bit about financial toxicity, but I think we need to develop skills in understanding what this means for an oncologic population. So this is a great paper from the melanoma literature identifying something called the COST score, a comprehensive score for financial toxicity, which incorporates several different parameters, which you can see here. And what it shows is that in immunotherapy survivors for melanoma, which in this case was defined as greater than 2 years, younger patients, not surprisingly, had a higher rate of financial toxicity and associated poor quality of life. We also heard a little bit about the ESMO MCBS score, the magnitude of clinical benefit score. I think this is an example of the first steps to incorporating this nuance. So this is a great scoring system developed by the ESMO group in which the efficacy outputs like OS, PFS, and DFS are incorporated with a quality of life assessment. And essentially for a curative regimen, this is graded as A or B, and in non-curative regimens, it is given a numeric score. And for every benefit in quality of life, the numeric score goes up. I think we need a little bit more nuance to this, but it's certainly a step forward. So what are the nuances in early stage disease? So I think chronic immune-related toxicity is obviously particularly important when we're going to give treatment in an early stage setting, and when we're talking about giving treatments for prolonged periods of time, or how much the adjuvant portion adds. We're understanding from Checkmate 816, 671, 77T, the proportions of patients who got toxicity, but we have no idea how long they had that toxicity for, how it impacted their quality of life, how it was treated. So this is a great paper from JAMA Oncology looking at this in melanoma. And we see, alarmingly, that in the adjuvant setting, 43% of these patients had chronic immune tox, where they required immunosuppression for longer than 3 months, sometimes 6 months, sometimes a year. And some of these were very complicated. 100% of them had some form of neurotoxicity, 83% endocrinopathies, ocular events. Only 14% resolved their immune-related toxicity by the end of study follow-up, which was 2 years in this case. We do not have these data in lung cancer, and we do not have these data in the early stage setting. So some of the learnings, again, from melanoma, timing, dose, and combination appears to matter. So this is a beautiful study that was in the plenary session of ASCO last year, the NADINA study, presented by Christian Blanc, in which 2 doses of neoadjuvant ipi-nivo was given for melanoma, followed by primary resection of the melanoma and lymph node dissection. And what he identifies here is there was double the rate of grade 3 to 4 immune-related adverse events in the neoadjuvant setting versus the adjuvant setting, and that the quality of the toxicities were quite different. Adrenal toxicity 7 times higher when given in the neoadjuvant setting. Some differences in surgery outcomes, not too many deaths. What we also see here, in again learning from melanoma, is that the surgical outcomes may be very different depending on the timing of immunotherapy. So I think really a growing body of evidence that we can't simply apply the data from metastatic disease to the data for early stage disease. Luckily, in lung cancer, we don't seem to see that much of a difference. Patrick Ford's data yesterday showing that really the addition of immunotherapy causing very modest differences in toxicity in the neoadjuvant setting only. And actually, some interesting data which was referred to by our surgical colleagues about is pneumonectomy necessarily need to be avoided when we see health-related quality of life very similar, whether a patient had a pneumonectomy or not. So studies like PRADO, in which total lymph node dissection was actually changed based on quality of life and others, I think is going to be instructive. One of the key questions in early stage disease, we talk about contribution of components with respect to efficacy. What about contribution of components with respect to toxicity? We see here that the neoadjuvant setting does appear to be the setting in which we see the most toxicity, but is it the toxicities that lead to chronic toxicity, that affect quality of life? That we don't know. This is the paper that we published from our Hopkins experience of immunotherapy survivors. 52% of those patients had experienced at least one immune-related adverse event, 27%, nearly a third, ongoing management for immune-related toxicities at 1 year. What we understand in early stage disease is that 26% of patients on Keynote 671 had IRAEs. 37% of them were ongoing at the time of data cutoff, and as per sponsor, there was no toxicity data available or collected beyond 90 days. So this is something that we as a field need to understand. So what are some of the new tools, new areas that we need to focus on? I think really what this is hearkening to is that we're moving to an area of survivorship. And how is survivorship defined in early stage lung cancer? Is it simply by the time? So we've seen 1 year, 2 years, 3 years, 5 years, many different definitions have been bandied around. So some specific tools to assess quality of life in this era. We now see some formal quality of life tools being developed for immunotherapy. So the same way we have FACT-L, FACT for lung cancer, now we have FACT-ICM, immune checkpoint modulator. And this was developed by a Canadian group, Aaron Hansen and colleagues, and published in Cancer in 2020. I feel this is something that should be incorporated into all our studies going forward. Also, our patient advocate leader gave a nod to AI. How can we use AI in the field of immune-related toxicity? So this is a paper that we presented at ESMO last year and should be coming out in publication soon. This is utilizing AI radiomics to predict which patients will get symptomatic pneumonitis. So in this paper, we looked at all of the patients enrolled in the Pacific trial and used quantitative lung imaging based on their CT scans, lung vessel segmentation, specific CT attributes, and their clinical demographics, and integrated them in a multi-parameter AI model. And what we identified is that the discriminative power of this has an AUC of 0.78, and this now subsequently needs to be validated in other data sets. We're also using some new tools to try to predict who may develop immune-related toxicity and why. So a simple proteomic-based biomarker, this is from the group of OncoHost, but there's several other proteomic biomarkers that could be evaluated, might actually link the biology of the toxicity to the toxicities in question. And this is data that we presented at the AACR last year. So why does all this matter, aside from giving the patient information and helping them to make the decision? Because actually the choice of immunosuppression we use for immune-related toxicity may actually also affect the outcome. So this is some very interesting data. I've started even reading rheumatology data. You have to be very broad these days. And in the rheumatology data, in patients who developed inflammatory arthritis, if they were treated with a simple immunosuppressive agent, methotrexate, these patients appeared to have reasonable arthritis control, but it did not compromise their cancer outcomes or risk of relapse. However, more sophisticated biologic therapies, like anti-IL-6 treatments, did a better job of controlling the arthritis, but the time to cancer progression was nearly double, or half the time. So actually, our choice of immunosuppression and understanding the biology of the toxicity may help us to even treat these patients better in terms of their cancer. We also need to use our sophisticated science to understand toxicity a little bit better. So this is a beautiful paper from the MGH group, led by Kerry Reynolds and some of the endocrinology colleagues, using polygenic risk scores to try to identify who is at risk for a rare but severe toxicity, type 1 diabetes, that can occur from immunotherapy. So in this paper, they calculated the germline genotype of over 800 patients at the Dana-Farber Cancer Institute, adjusted for age, sex, and 10 other principal components of genetic ancestry. And then they took the top 10% and identified a risk score that was associated with a 4.5-fold increased risk of type 1 diabetes. And this had a predictive capability with an AUC under the ROC curve of 0.76. So this is something, again, where we could do a risk scoring assessment ahead of time to try to understand who is at risk for toxicity and who should be proactively monitored by some of our allied specialists. A similar analysis here done for inflammatory arthritis, looking at HLA genotypes, identifying that there are specific HLA alleles that are associated with the increased risk of inflammatory arthritis. So with all this information, aside from giving the patient the information and adapting our risk stratification, what else can we do? So this is some very interesting work from around the globe, looking at seeing if we can change how we give immunotherapy. This is on the right-hand side, you see a paper from India using a biologically effective dose of 0.3 milligrams per kilogram. So basically, if we give 1/10 of the dose of immunotherapy to patients with head and neck cancer, we might get the same benefit. If we modify the dose, how does this affect toxicity and how does this affect quality of life? So I think there are a lot of ways we can actually adapt our treatment strategies with respect to risk stratification, prediction, dose, duration, and schedule that will help the patient, but may also level the playing field in terms of global access to some of these treatments. So in summary, there has been significant impact in the use of systemic therapy for early-stage lung cancer, and this spans both targeted therapy and immunotherapy. And this really has led to several newly established standards of care. However, our long-term toxicity data is limited to potentially non-existent in several of these groups. What is a balanced assessment of impact? I think we have to quantify the total burden of toxicity. We have to apply the same biologic rigor we use for efficacy to toxicity and identify immune-related toxicity incidence, spectrum, and subtypes. We need to expand this to surgical adverse events, time toxicity, financial toxicity, and patient-reported outcomes. Particular nuances for early-stage disease, chronic toxicity, challenging the old dogmas of surgical toxicities and the impact of timing, duration, and other related efforts with respect to timing. New tools for the era of survivorship will be to truly quantitate what is the risk-benefit calculus, which is different for early-stage disease as opposed to metastatic disease. Use some of these new tools, quality of life, biologic biomarkers, and AI. And from here, it would be wonderful for our patients and for the field to have a tailored toxicity risk assessment and a tailored toxicity treatment schedule that takes toxicity into account, adapting dose, duration, and route. With this, I'd like to thank you all for your attention and happy to take questions.